Dear audience, let me present my PhD topic, which is improving postoperative outcomes after cardiovascular surgery. My name is Nikolett. I'm a specialist in anesthesia and critical care at the Városmajor Heart and Vascular Center. My vision is for science to prevail over routine, and to achieve that, I would like to implement standardized perioperative protocols in cardiovascular anesthesia to minimize postoperative complications. I'm going to talk about two of my projects today. My first project is investigating the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury by the methodology of systematic review and meta-analysis. So we know that cardiac surgery-related acute kidney injury develops quite commonly in adults undergoing cardiac surgery, and in severe cases it may increase mortality up to 60%. Currently there are no therapeutic treatments available, only supportive care, so its early recognition and prevention is essential. There are certain preventive measures recommended by the KDIGO group, which can be introduced if we are able to identify these patients in the early phase. We know that we use the KDIGO criteria to define and identify patients with acute kidney injury, and it is also true for the cardiac surgery-related acute kidney injury, but we are only able to do so once the functional loss has already happened. So we would really need predictive tool, and urinary biomarkers have been investigated widely in several critical conditions and have moderate predictive value to predict the development of AKI. So our aim was to determine the diagnostic accuracy of urinary biomarkers in cardiac surgery-related acute kidney injury. Our hypothesis was that we can predict the CS-AKI with urinary biomarkers, and if we detect these high-risk patients early, then we can introduce the preventive measures and reduce the development of AKI. We performed our systematic search with this search query, and after the selection process, we ended up with 86 articles. We quantitatively analyzed 79 articles reporting on 11 biomarkers. We have tremendous amount of data, but I'm going to show you three groups about the individual biomarker prediction, the predictive value of clinical models, and the predictive value of combination of urinary biomarkers. On this first table, you can see the individual biomarker prediction of all stages and severe cases of AKI at different measurement time points. You can see that the individual urinary biomarker measurements measured in the intraoperative and early postoperative period give us an AUC around 0.75, which means that only 3/4 of these patients are accurately identified with the measurement of urinary biomarkers. If we combine the urinary biomarkers for prediction of stage 2 and 3, so the severe cases of CS-AKI, we can see that we can identify around 85% of patients developing this severe complication, which gives us an excellent predictive value. We were also able to pool data regarding clinical models and scoring systems, and also clinical models and scoring systems enhanced by the addition of urinary biomarker measurements. So if we combine the urinary biomarkers with the clinical models or scoring systems, we can also achieve almost excellent predictive value. So as a summary, we have some strengths. It's a most comprehensive study in the evaluation of CSA-KI predictor urinary biomarkers. It answers a highly relevant question. One of our limitations is a high risk of bias due to the inconsistent reporting, and also we were not able to stratify according to patient heterogeneity. As a conclusion, we can say that individual urinary biomarkers have acceptable accuracy. If we combine the urinary biomarkers with each other or with clinical prediction models, we can achieve excellent accuracy. So we would advocate to use the combination of biomarkers and combining them with clinical prediction models. And this field has been widely researched, so probably known urinary biomarker prediction models should not be researched further, but rather novel biomarkers should be researched. We presented this to congresses. We are about to send the manuscript for internal review. And my second project is a protocol of a randomized clinical trial. It's about hydroxycobalamin for vasoplegic shock after cardiac surgery. So we know that vasoplegia affects around 20% of patients after cardiac surgery, which was performed on cardiopulmonary bypass. In high-risk patients, the incidence is even higher, and the mortality of refractory vasoplegia is also very high. We treat these patients with high-dose vasopressors and arginine vasopressin. Vasoplegia is caused by nitric oxide release in the peripheral tissues. We have a drug, which is hydroxycobalamin, which is used in high doses in cyanide poisoning, and it has a favorable side effect, which is hypertension. There are no contraindications and no toxicity according to the CDC and the EMA. So we lack evidence if high dose of hydroxycobalamin can effectively treat cardiac surgery-associated vasoplegia. So our aim was, or will be, to investigate the efficacy of high-dose hydroxycobalamin versus placebo in this patient population. We would like to include patients who are post-cardiac surgery, performed on cardiopulmonary bypass, who develop refractory vasoplegia, and give them hydroxycobalamin or give them placebo, and as an outcome, measure the cumulative dose of vasopressors, and safety and other outcomes like length of ventilation, length of ICU stay will be also investigated. So the inclusion criteria consists of adults who develop the refractory vasoplegia, which is defined by severe vasoplegia despite adequate fluid resuscitation and adequate cardiac output, which is treated with high doses of vasopressors. And we would exclude B12 depleted patients, emergency surgery, patients on CRRT, and transplant and ventricular assist device patients. We would like to give 5 grams of hydroxycobalamin IV or placebo, and we will measure the cumulative dose of vasopressors, and then the organ support-free days, and also other safety outcomes like infective complications and intensive care and hospital stay. So we are currently at the preparation of the protocol. This is the summary of my 2 projects, and thank you very much for your attention.
Thank you very much for the excellent presentation. So how can we imagine these biomarkers in the clinical practice? When do we have to determine them? How long does it take to get the results before the surgery, during the surgery, or after the surgery?
So these biomarkers should be measured in the intraoperative and in the early postoperative phase according to our results. And there is only one, which is the TIM2, IGF-BP7 biomarker, which can be measured at bedside. There is a it's called a nephrocheck. It's a bedside test, and it gives us results in 20 minutes. And all the rest has to be sent into labs, and they are usually measured in batch, so they can only be used for research purposes currently. So there is only one, which can be used at the bedside.
Congratulations, and especially congratulations on initiating a patient study, a clinical study. I would have a question about the feasibility of that your second project. Yes. How many patients you expect to treat, and how many would you need to observe the outcome differences between the groups?
We haven't made the sample size calculation yet. As a feasibility, so how common this problem is at our center, I would say that it happens, we have at most 4 cardiac surgical cases per day, but that's the most. Usually it's rather 3 or 2. And we have, there is a tendency that we have higher and higher risk factors for these patients, so they are more prone to develop this refractory vasoplegia. But every second day we have one, so I think it's quite common. So we can calculate with 2-3 patients per week.
Thank you for the presentation, Nikki, even though I've heard it before. I have a question about your protocol, so the second project.
Yes.
Most of your safety outcomes sound a lot more like efficacy outcomes, because you would hopefully be, you're expecting to reduce the length of stay and to reduce the post-operative complications, I presume. Are there any hydroxycobalamin specific adverse events that you could be looking for?
There are no, thank you for the question, there are no severe adverse events reported in the literature. Most adverse events, so the most severe side effect is hypertension, which we want to use, actually, and all the rest are, I think, like nausea, diarrhea, dizziness. So I think they are minor side effects, and these patients are sedated, intubated, and ventilated, so we wouldn't be able to observe these. So I can't really think of any adverse.
Congratulations, Nikki, for
Thanks.
the nice work. My question regarding your second project, and I would like to ask that how did you choose the dosage of hydroxycobalamin?
The dose is the dose of the cyanokit, which is given in cyanide poisoning. That's the 5 grams. And also there have been some case reports and case series who use this very high dose, and they even repeat it once there is no effect. So they come up to 10 grams of total dose. So it's kind of arbitrary, but the cyanokit comes in 5 grams dose.